Welcome to the deep dive. Today we're tackling a really complex area, ophthalmic pharmacology. I mean, the eye, it's like a world unto itself, isn't it?
It really is, and treating it needs these very specialized drugs, ones that can get where they need to go without, causing problems elsewhere in the body.
So that's our mission today. We're going deep into the essentials from our source chapter mechanisms, uses, side effects, and crucially, the nursing side of things.
Exactly. We want you, the listener, to really grasp why these drugs are used the way they are, not just what they do. It's all about safe and effective care.
Okay, before we jump into the drugs themselves, let's set the stage. The main condition we're usually talking about is glaucoma. Can you give us the quick version of what's actually going wrong in the eye with glaucoma?
Sure, it boils down to pressure, intraocular pressure, or IOP. It gets too high because the fluid inside the eye, the aqueous humor, can't drain out properly. Think of it like a sink backing up.
And that backup happens often near something called the canal of Schlemm.
That's a key drainage pathway, yeah. When it's obstructed, the pressure builds, and that pressure starts to damage the optic nerve. That's the real danger.
Got it. And because we're manipulating eye structures, there are three key terms for actions we'll hear a lot. Miotics,
Miotics constrict the pupil, make it smaller. Miosis.
mydriatics,
They do the opposite, dilate the pupil. Mydriasis.
and cycloplegics.
Sounds serious.
They are. They paralyze the ciliary muscle.
Yeah.
This stops the eye from focusing or accommodating. Useful for exams, sometimes treatment.
Okay. And glaucoma itself isn't just one thing, right? There are two main types we need to differentiate.
Absolutely critical distinction. You've got open-angle glaucoma. That's the common one. It creaks up slowly. It's chronic. The drainage angle looks okay, but the tissue itself isn't working right, so the fluid outflow is just sluggish.
Slowly progressive. And the other, angle closure glaucoma. That's the emergency. It's acute, can come on suddenly, very painful. Here, the angle between the iris and cornea actually narrows or closes off, blocking drainage almost completely. Big pressure spike, risk of rapid vision loss. Very different situation.
Okay, so whether it's slow or sudden, the goal is always the same. Get that pressure down.
That's the core strategy, yes. Reduce the IOP, and we do that basically two ways. Either help the fluid drain out better or make the eye produce less fluid in the first place.
Let's start with increasing the drainage. First up, cholinergic drugs, the miotics.
Right. Now, these stimulate the parasympathetic system in the eye. They cause miosis, pupil constriction, and also make the ciliary muscle contract.
And how does constricting the pupil help drainage?
It's clever, really. That constriction and muscle contraction physically pull on the trabecular meshwork, the eye's drainage channels, stretching them open wider.
Ah, so you're literally widening the drain pipe.
Exactly. Better outflow, and you can see IOP drop by, say, 20 to 30%. Now, there's a big difference in how long they work. You've got direct-acting ones like acetylcholine, very fast onset, maybe minutes, but they only last about 10 minutes. Great for during surgery.
Quick in, quick out.
Then you have indirect-acting ones like echothiophate, much longer duration. We're talking effects lasting anywhere from a week to almost a month. More for chronic management.
That duration difference is huge clinically.
Yeah.
And you mentioned something interesting about eye color.
Yeah, this is a fascinating detail from the text. If you have darker eyes brown, hazel, these miotics might not work quite as strongly.
Why is that?
The pigment in the iris actually absorbs some of the drug. Less drug reaches the receptors, so the effect can be, well, a bit muted compared to someone with blue eyes, for instance.
Huh. Good to know. Okay, moving on to the sympathomimetics. These are mydriatics. They dilate the pupil. Now, wait, if constricting helped, how does dilating help?
Right, seems like a contradiction, doesn't it? But they work on different receptors, the sympathetic ones, alpha and beta. It's a bit more complex.
Okay.
So alpha stimulation actually seems to increase the outflow of aqueous humor through a different pathway, and beta stimulation seems to decrease the production of the fluid.
Ah, so it's attacking the pressure problem from two angles, even though it dilates.
Precisely. And a good example here is dipivefrin. It's what we call a prodrug of epinephrine. It's designed to be more fat-soluble.
Why does that matter?
Better penetration into the eye tissues. And crucially, it gets converted to epinephrine inside the eye. This means less gets into the bloodstream, so you have fewer of those systemic side effects like racing heart or tremors that you might get with regular epinephrine. Clever pharmacology.
Definitely smarter design for fewer problems. Okay, next big category. Beta-adrenergic blockers. These are common, right? Like timolol.
Very common. Workhorses for glaucoma. Their main strategy is turning down the tap. They primarily reduce IOP by decreasing the formation of aqueous humor.
Less fluid being made.
Exactly. Now, timolol is non-selective, meaning It blocks both beta-1 and beta-2 receptors.
And that matters because?
Because beta-2 receptors are in the lungs. So if timolol gets absorbed systemically, it can cause problems for someone with asthma or COPD. That's a big nursing consideration.
Right, so what's the alternative?
You might use betaxolol. It's beta-1 selective, mostly targets receptors in the heart, so there's less risk of respiratory side effects. Still need to be careful, but it's often a safer choice for those patients.
And timolol has that gel formulation too.
Yes, which is convenient. Forms a sort of depot, allows for just once-a-day dosing. Big plus for adherence.
Makes sense. Okay, how about carbonic anhydrase inhibitors, CAIs? Dorzolamide is an example.
Right. These also work on the production side. They inhibit an enzyme, carbonic anhydrase, which the eye needs to make aqueous humor. So less enzyme activity, less fluid production.
Straightforward enough. Any big warnings here?
Yes, a major one. CAIs are chemically related to sulfonamides, sulfur drugs.
Oh, so potential for allergy cross-reaction.
Exactly. If your patient has a known sulfa allergy, you have to be extremely cautious with these. Monitor them closely for any reaction. It's a key safety point.
Definitely one to flag. Now, sometimes you need really rapid pressure reduction, right? Emergencies.
That's where the osmotic diuretics come in. Think acute angle closure crisis, or maybe right before or after eye surgery.
How do they work so fast?
They make the bloodstream hypertonic, really concentrated. This creates a strong osmotic gradient. Basically, the blood becomes like a super sponge, pulling water out of the eye from both the aqueous and vitreous humors and into the vessels.
Like vacuuming the fluid out.
Pretty much. Reduces the volume inside the eye very quickly. Glycerin is often used first. It's oral. Mannitol is given IV for a really potent effect.
Got it. Emergency use mainly. And the last glaucoma class, prostaglandin agonists. Latanoprost is the big one here.
Yes, these have been game changers, largely because you only need to use them once a day.
How do they work?
They increase the outflow of aqueous humor, but through yet another route, the uveoscleral pathway. It's a secondary drainage system. By enhancing this, they lower IOP effectively over 24 hours.
So convenience is a major plus,
Yeah.
but they have that one very unique side effect.
Ah, yes. The eye color change. This is something patients absolutely must be counseled about beforehand.
What happens exactly?
If you have lighter colored irises, hazel, green, blue, brown, these drugs can permanently increase the brown pigment. Your eyes can turn brown or browner, and it doesn't reverse even if you stop the drug.
Wow, permanent. That's a significant cosmetic effect. Definitely needs a thorough discussion about body image and expectations.
Absolutely. Okay, so we've covered managing pressure. Let's switch gears now to dealing with infections and inflammation in the eye.
Right, because problems aren't always about pressure. Infections happen. What do we use?
Depends on the bug, of course. We use topical antimicrobials. For bacteria, you might see aminoglycosides like gentamicin or maybe erythromycin. For fungal infections, something like natamycin. For viral, like herpes keratitis, maybe trifluridine.
And erythromycin ointment has that specific neonatal use, doesn't it?
Yes, that's standard practice. It's applied to newborns' eyes right after birth to prevent conjunctivitis caused by gonorrhea or chlamydia exposure during delivery. Really important preventative measure.
Okay. Now for inflammation. We've got corticosteroids, like dexamethasone, and NSAIDs, like ketorolac. They both calm inflammation, but how?
They work at different points in the inflammatory cascade. Corticosteroids are broad hitters. They inhibit an enzyme called phospholipase A2 way upstream. NSAIDs work further down, inhibiting cyclooxygenase or UX enzymes.
So different mechanisms, but similar goal. Reduce swelling, redness, pain, prevent scarring, maybe after surgery or an injury.
Exactly. Often used post-op, like after cataract surgery or for certain inflammatory conditions. Sometimes NSAIDs are preferred first because they're generally less immunosuppressive than steroids.
But there are big safety warnings with both, aren't there? Especially about infection risk.
Huge warnings. Because they suppress the immune response, you absolutely do not use them. If you just have a minor scratch or if there's any suspicion of an active infection, they can make things much, much worse by lowering the eye's defenses.
And long-term steroid use has its own dangers.
Definitely. Prolonged use can lead to serious problems. Cataracts, increased IOP, ironically glaucoma, and even optic nerve damage. You have to use them judiciously and monitor closely.
What about the NSAIDs like ketorolac? Any specific watch-outs?
Yes, ketorolac specifically carries a warning about potentially delaying corneal wound healing. In some cases, it might even lead to breakdown of the corneal surface. So again, close monitoring is key, especially if used for more than just a few days.
Okay, let's quickly touch on drugs used for diagnosis and numbing.
Right, diagnostics. Fluorescein dye is essential. You put a drop in, and if there's an abrasion or defect on the cornea, it stains it bright green or yellow-orange under a special blue light. Foreign bodies show up with a little green halo around them. Very useful.
And for getting a good look inside the eye during an exam.
That's where those cycloplegic mydriatics come back in like atropine or cyclopentolate. They give you maximum pupil dilation and paralyzed focusing so the examiner can get a clear, stable view of the retina and optic nerve.
Makes sense. And for procedures, that might be painful, like getting something out of the eye.
Topical anesthetics. Tetracaine is a common one. It numbs the surface of the eye really quickly, like under 30 seconds.
How long does the numbness last?
Not long, maybe 15, 20 minutes. Just enough for a short procedure. But here's the critical safety point. These are only for short-term professional use.
Why not for ongoing pain relief?
Because repeated use can seriously damage the cornea. It can delay healing, lead to thinning, even perforation and permanent vision loss. Patients should never be sent home with a bottle of anesthetic eye drops. Very dangerous.
Got it. Strictly supervised use. And just briefly, the miscellaneous agents. Allergies, redness, dry eye.
Yep. Quick one down. For allergies, you've got antihistamines like olopatadine or mast cell stabilizers like cromolyn. For just redness relief, decongestants like tetrahydrozoline, they constrict blood vessels.
Like Visine, basically.
Similar action, yes. And for dry eyes, of course, artificial tears for lubrication. Plus, there's cyclosporine, Restasis, which is different. It actually helps your eye produce more of its own tears over time. Immunomodulator.
Okay, comprehensive list. Now let's bring this all together with the nursing process. Because knowing the drugs is one thing, but giving them safely and teaching the patient effectively is everything.
Absolutely paramount. Proper technique is non-negotiable for safety and making sure the drug actually works. So number one, instill drops or ointment into the conjunctival sac.
That little pocket you make by gently pulling down the lower eyelid.
Exactly. Never, ever drop it directly onto the cornea. That can cause injury and it's uncomfortable. Have the patient tilt their head back and look up at the ceiling.
And the absolute must not do.
Do not touch the tip of the dropper or the tube to the eye, eyelid, or anything else. Contamination is a huge risk. You could introduce bacteria right into the eye or contaminate the whole bottle.
So important. Now, you mentioned systemic absorption earlier, especially with beta blockers. How do we minimize that?
This is a critical step for the patient to learn. Immediately after putting the drop in, they need to apply gentle pressure with their finger to the inner canthus, the corner of the eye, right next to the nose.
For how long?
For at least a full minute, or whatever the specific construction is. This blocks the tear duct, the nasolacrimal duct.
Why block that duct?
Because that's the drainage route into the nasal cavity. And from there, the drug gets absorbed into the bloodstream like any other systemic med. Blocking it keeps more drug in the eye where it's needed and dramatically reduces the chance of side effects like slowed heart rate or breathing problems from, say, timolol.
This is perfect sense. Keep it local. What if a patient needs to take more than one type of eye drop?
Good question. You absolutely must wait between different types. The standard recommendation is at least 5 minutes.
Why wait?
To give the first drop time to absorb, if you put the second one in right away, you basically just wash the first one out. Reduces the effectiveness of both.
Okay, 5-minute rule. And any final key teaching points for patients?
Definitely. If they're using mydriatics, the pupil dilating ones, tell them to expect photosensitivity, light sensitivity. Sunglasses are a must when they go outside.
Makes sense. Bigger pupil lets in more light.
And if they've had a topical anesthetic applied in the clinic, stress not to rub or touch that eye. They can't feel injury if it happens. Sometimes an eye patch is used for protection until the feeling comes back.
Good safety tip.
And universally, instruct them to report any serious signs, immediately worsening eye pain, increased discharge or pus, fever, or any sudden change or loss of vision. Don't wait.
Okay, so wrapping this up, what's the big picture takeaway? We've seen it's about balancing fluid dynamics for glaucoma-boosting outflow or cutting production.
Right. And for infections and inflammation, it's about targeted antimicrobial use and being really mindful of the double-edged sword of anti-inflammatories, the relief versus the risk to the eye's structure and defenses.
Which brings us to a final thought. You mentioned the risks with NSAIDs like ketorolac possibly delaying healing and long-term steroids like dexamethasone potentially causing cataracts or glaucoma.
Exactly. So this raises an important question for us all, providers and patients. How do we best make that trade-off? When you need to control acute inflammation quickly, how do you balance that immediate need against the potential long-term risks to the eye's structure, its integrity, its clarity?
It's not always an easy call, is it?
No, it really isn't. It requires careful consideration of the individual patient, the specific situation, and vigilant follow-up. Something definitely worth mulling over.
A perfect point to end on. That really highlights the nuances here. This has been a fantastic deep dive into ophthalmic pharmacology. Thank you for breaking it down so clearly.
My pleasure. It's crucial information for safe practice.